Welcome to the explainer. You know, before anyone can even dream of scrubbing into an OR, they've got to master the absolute basics, the language of surgery itself. And that language, it starts right here with a simple suture. So today we're going to unravel the critical skill of choosing the perfect one for the job. All right, let's just jump right in with a high-stakes situation. Imagine this. A patient's femoral artery is bleeding out. You're the surgeon. What do you grab? See, this isn't just about picking some thread. It's about engineering a life-saving repair on the spot. And trust me, by the end of this, you'll know exactly what to do. So before we even get into all the different materials, we've got to get the fundamentals down. And the most basic thing you need to know is suture sizing. Now, it's a little weird, kind of counterintuitive, but I promise, once you crack this code, you're well on your way. This system, it's basically the universal language surgeons use to talk about how thick a suture is. But why does that even matter? Well, it's simple. The diameter is directly tied to its tensile strength. In other words, how much pull it can take before it snaps. We're talking the difference between a repair that holds strong and one that doesn't. Okay, this right here is the single most important rule you need to remember about suture sizing. And heads up, it's going to feel totally backward at first. You absolutely have to burn this into your brain. The bigger the number with the O, like say a 6-0, the smaller the thread actually is. And the smaller the number, like a 1 or a plain 0, the thicker and beefier it is. Weird, right? All right, let's look at this table to make it super clear. Up at the top, you've got a size 1 suture. Think of this as a thick, heavy-duty thread. You'd use this to close something really tough, like the abdominal wall. Now, as you go down the chart, you see the numbers get bigger, right? You go from a 3-0 to a 6-0. But look at the suture itself. It's getting thinner. A 6-0 is so fine. We're talking almost as thin as a single hair. That's what surgeons use for incredibly delicate stuff, like repairing tiny blood vessels or working on the face. Okay, so we've got sizing figured out. Now we come to the next huge decision point. Every suture you'll ever see falls into one of two big categories. And this is really the first fork in the road for a surgeon. Is this stitch going to dissolve on its own? Or is it going to stay in there forever? Here's a simple way to think about it. An absorbable suture. It's basically a temporary scaffold. Its job is to hold everything together just long enough for the body to do its healing thing. And then, poof, it dissolves. It's perfect for those deep tissue layers. On the flip side, you have non-absorbable sutures. These are permanent implants. Think of them like tiny little rivets that are meant to provide support for life. Absolutely essential for things like heart valve repairs or, sewing blood vessels back together. All right, now for the fun part. Let's get into the actual materials. I mean, sizing and whether it absorbs, those are the rules of the game. But the materials themselves, that's the surgeon's toolkit, their arsenal. And believe me, each one has its own unique personality and a very specific job it's designed to do. So let's start with PDS. This stuff is a true workhorse in the OR. It is absorbable, but here's the cool part. It sticks around for a good 3 months, giving long-lasting support. That makes it perfect for tissues that take a while to heal and are under a lot of stress, like the fascia, which is that super strong connective tissue in your abdominal wall. It's also a go-to for what we call visceral anastomosis. That's just the fancy surgical term for reconnecting parts of the intestine. Okay, now let's look at a non-absorbable one, polypropylene, but you'll almost always hear it called Prolene. What's special about this one is that it's incredibly smooth. It's like it glides through delicate tissue, like a blood vessel wall, without tearing it up. And since it's permanent, you know that repair is going to hold up against the constant pounding of blood flow forever. It's really the gold standard for any kind of vascular work. This table is basically the surgeon's cheat sheet, so let's just pause here for a second. See Vicryl? That's an absorbable one, and it's pretty much gone in about 6 weeks. That makes it a real go-to for closing up deeper layers of tissue. Then you've got something like Silk, a total classic, non-absorbable, and surgeons love it because it's just so easy to handle and ties a really secure knot. And yep, there's our PDS and Prolene we just talked about. The big takeaway here, every single material on this chart is a specific tool for a specific job. There's no one-size-fits-all. So we've gone through all the theory, the sizing, the types, the materials. Now it's time to put it all together. Let's throw some real-world clinical scenarios at you and see if you can put this knowledge to the test. Try to guess the right suture before I give you the answer. And here we are, right back where we started, that femoral artery. But now you've got the mental framework to solve this puzzle. So what do we need to think about? Well, it's a high-pressure vessel, right? And whatever we do, that repair has to hold forever. So what's the answer? You've got it.
The key is picking a non-absorbable, permanent material, in this case, polypropylene. And you'd want a nice fine size, like a 5/0, so you can create a perfect leak-proof seal without messing up the artery wall. It's exactly what we said before. You need a permanent rivet for a permanent job.
Okay, scenario number 2. Your patient just had major open surgery, and now you have to close up the abdominal wall. Specifically, that tough layer called the fascia. Now remember, this is the layer that keeps everything in and prevents hernias. So it's under a ton of tension, and it needs some serious, long-lasting support while it heals. And the perfect choice here is a size 1 PDS. Let's break down why. First, you need serious strength, so you grab a thick size 1 suture. But you also need that strength to stick around for the entire 3 months it takes for the fascia to heal up properly. And that's exactly the job PDS was made for. It holds strong for that whole time, and then it just dissolves away. All right, last one. We're doing an inguinal hernia repair, and it's time to close the skin. The game's a little different now. Yeah, we need strength, of course, but we're also really focused on getting a great cosmetic result, minimal scarring. And if we can, we want to make the whole healing process easier for the patient. And this is where your choice makes a huge difference for the patient's experience. You'd go with an absorbable suture, something like a 3/0 PDS or Vicryl, and you'd place it just underneath the skin. It's a technique we call a subcuticular closure. What happens is the stitch just dissolves on its own. The skin heals up beautifully, and the best part? The patient doesn't have to make another appointment just to get their stitches taken out. It's just elegant, smart, and efficient. So you can see just how deep and how critical this knowledge is, right? But it does make you wonder, with all the new tech coming out, surgical glues, fancy staplers, what's the future for the good old needle and thread? And that's a really good question to ask, because even as technology races forward, the basic principles of bringing tissue together, the feel a surgeon gets through their fingertips, the simple elegance of a perfect suture line, I have a feeling that's going to be a cornerstone of surgery for a very, very long time.